The following podcast is part of a certified educational activity titled Exploring the Promise of Biomarkers and ATTs in Diagnosing and Treating Early Symptomatic Alzheimer's Disease. Key takeaways from ADPD 2025 and AAN 2025. Access the entire activity and complete the post-test at peerview.com/BRK860. Downloadable slides are also available.
Great. It's a great pleasure to give him this talk. My name is Professor Nick Fox. I work at the Institute of Neurology in London, and I'm Professor of Neurology and Director of Dementia Research. And I'll be talking about biomarkers and anti-amyloid therapies in diagnosing and treating early symptomatic Alzheimer's disease. And there's some takeaways from some recent conferences which I think are really exciting. I think the field's changing at a remarkable rate. So the goals for today are to increase the awareness of the benefits of diagnosing Alzheimer's disease early on, improve understanding of the latest evidence about biomarkers in these therapies, which will improve diagnosis and treatment of patients, talk about how we integrate biomarker testing into clinical workflow to improve and facilitate a timely diagnosis and strengthen skills of those which we all are learning about selecting patients for anti-amyloid therapies and for monitoring the effects of treatments. So despite huge advances, technical advances in diagnostic capabilities, and now that we've got disease-modifying therapies, there are a lot of gaps. There's tremendous underdiagnosis and dreadful delays that would not be tolerated in many other diseases, and that will reduce the opportunity to give treatments when they may be most efficacious and when people will want those therapies. And the lack of use of diagnostic biomarker testing, and particularly with delays in implementation of blood biomarkers, will be a barrier. It already is a barrier for these therapies that do require biomarker confirmation. And we're gaining real-world evidence. So at the moment, we've got relatively limited knowledge in key details about implementation from delivery, monitoring, safety, etc. And a key barrier, which I'll be talking about later, is relatively limited access to MRI in many parts of the world, which is a barrier because not just to diagnosis, but also to disease-modifying therapies, where they are a prerequisite for the anti-amyloid or the amyloid-targeting therapies. And as clinicians and in clinical practice, there's relatively little awareness of strategies that can reduce the risk of ARIA-E, including in people who are E4 homozygotes. So there are lots of benefits in receiving a timely and accurate diagnosis. Anybody who's worked with families recognizes that. It validates patients' concern. I've had patients, families who've said to me, it's an agony of not knowing that there's something wrong. So we're not talking about screening here. This is when people feel there's something wrong. It may be family, it may be the patient as well. And if you can get a diagnosis which is relatively precise, it removes uncertainty, it enables them to participate in decisions about their future when they still have that capability before that's too late. It empowers them to make changes, maybe just how they want to spend their time, but also how they want to manage their own comorbidities. It facilitates access to it, which without a diagnosis is just not available, to get support, to benefits, to knowing more about the disease. Without a label, without a diagnosis, you don't have this access. And it is now going to be crucial, essential for treatment with these disease-modifying therapies. We require a disease-specific diagnosis for a disease-specific treatment. And trials are available, and a diagnosis facilitates taking part in research or trials. So now, turning to these new therapies, we have lecanemab and donanemab have been licensed by the FDA and being licensed around the world at a growing level. Varies by region, but this is a growing field. In terms of inclusions, individuals have to have a clinical diagnosis of MCI and mild dementia, because that was done in the trials. And this is from the appropriate use recommendations at the bottom of your screen. You can see the references there. In the lecanemab trial, people had to have mini mental of 22 or above, and for donanemab, it was 20 and above. But it's essentially, it's have you got early Alzheimer's disease? And ApoE genotype testing is recommended because of the associated risks around ARIA-E in particular. The exclusions are very much to do with um, risk of having ARIA. And so a baseline MRI with evidence of CAA, so more than 4 microhemorrhages, greater than 1 macrohemorrhage, uh, and so on, as you see listed there, means that you're at higher risk of ARIA-E and ARIA-H, and therefore are on the recommendation for an exclusion. And clearly, if you are going to have to monitor with MRI, an exclusion is a contraindication to MRI, which could include claustrophobia. And you'll see down there, there's others, as you might imagine, anticoagulant use, bleeding disorder, unstable other condition, history of immunological disease. There are differences around the world in terms of who is eligible. In the UK, if you have ApoE4 homozygosity, so 2 copies, you're not eligible, whereas in the US you are. And this varies by country. So, turning now to what we've seen in recent conferences about um, how we might reduce the risk of ARIA-E. This is from Alzheimer TRAILBLAZER-ALZ 6, a donanemab trial. In the original FDA registration trial, TRAILBLAZER-ALZ 2, ARIA-E occurred in 24% of the donanemab group. So the hope with ALZ 6 was, could modified titration reduce this? And the little cartoon you see there, or the figure there, says the standard regimen, which was in the licensing as trial at the ALZ 2 trial, the people had 2 vials on their first dose, 2 vials on their second dose. These are monthly, then 2 vials on their third, and then they finally went up to the higher dose of 4 vials. So that's 700, 700, 700, and then 1,400 milligrams, because each vial is 350. So very slight change was made, so that those first 3 doses, the dosing ramped up more gradually. So 1 vial, then 2, then 3, then 4, and that's in red, a modified titration. So the first question was, did that alter the level of amyloid reduction that was uh, achieved? And really, I think all you need to focus on is the graph on the right. So in red, as I mentioned, is the modified titration, and standard in blue is uh, the, um, the standard dosing regimen. And what you can see is those 2 lines, the red and blue, are almost superimposed. They're almost identical, so that you see the mean amyloid level on the y-axis dropping down considerably by about 60 centiloids after only 24 weeks, and going down to more than 70 centiloids mean reduction by 52 weeks, by 1 year. So no loss of amyloid reduction as far as we can see, certainly by 52 weeks. What about risk of ARIA? Well, in blue, the standard dosing, very much very similar to the original trial in the TRAILBLAZER-ALZ 2, but the modified titration in red, we can see as we go across on the x-axis, it's days in that graph on the left. By about a year, you can see the red level of ARIA-E being much lower. So, and then if we look at severity, which is the little graph, a bar chart on your right, what we can see in green is those people who did not get ARIA-E. It's a broken y-axis, and you can see with the standard dose, it's about 3/4, 75% or so, did not have any ARIA-E. With modified titration, that goes up to about 85%. And we can see that the severe, the moderate, and mild levels of ARIA-E were all reduced. So reducing risk and the likelihood that you have a severe ARIA by this modified titration. And that extends right across the different ApoE genotypes, with homozygotes seeing this, which is on the left of your graph there, showing the greatest percentage reduction in risk of ARIA-E. but extending across all the different genotypes. But that's where the biggest difference is being made. And of course, that's most important because those are the people who are more at risk of having ARIA-E and of severe ARIA-E. Just pulling out a few key things here I've highlighted in red. There are many things that were looked at between the standard and the modified titration arms. The headline figure, ARIA-E reduced from 24%, so spot on what was done in the original trial, down to 16%, 15.6. So that's in that top red box. And notably, symptomatic individuals were about 5% in the standard dosing, and the modified titration, it comes down to less than 3%. And then also reduction in superficial siderosis. So that, I think, is really exciting. The next question is, what about outcomes if the anti-amyloid therapies are started earlier in the disease? And that has been a hope, a belief for really at a theoretical level. And now we're seeing empirical trial-based evidence coming out here. So if we looked at the original TRAILBLAZER-ALZ 2, this is a pre-specified subpopulation that was looked at, taking those who are mildest. So MCI, mild cognitive impairment, with a baseline MMSE of 27 or above, and in addition, also having low medium tau burden. Because one of the beauties of the ALZ 2 trial is that people also had a tau PET scan. So their level of tau in the brain could also be assessed. This is the primary outcome measure, the IADRS. It's an integrated measure of global AD severity, measuring both cognition and function. And what we can see is in the overall population, so much bigger numbers on the left, there's a 22% slowing. In the more mild individuals, the MCI with low, medium tau, we see slower declines, as would be expected, because people are milder, slower rates of progression if you're milder. But the percentage relative reduction in the decline is greater, with about a 60% slowing over those 76 weeks or 18 months. And the same is seen here with CDR sum of boxes, with the similar numbers being 29% slowing in the overall population. If we go mild to MCI with low to medium tau, it's almost a 46% slowing. And again, the curves are shallower, but also the percentage reduction is greater. So overall, there's the take-home message is that the importance of diagnosing and treating at the earliest symptomatic stages of Alzheimer's disease is likely to give us the greatest benefit to our patients. And again, will be when I think people will most want their therapies. But that is when we have to be able to diagnose early enough to be able to give therapies at this stage before they miss that important window where they benefit the most. Moving on now to another talk, an interesting talk given at ADPD. One of the questions has been about amyloid-lowering therapies is, well, how closely related is the cognitive benefit to the amyloid lowering? Well, we know that in the key studies of lecanemab and donanemab, both amyloid lowering was achieved and cognitive uh, improvement was achieved. So a slowing of decline rather than improvement. So improvement relative to placebo, just to be clear. So we would hope there'd be some correlation, but it might not be that close. It may not be a one-to-one relationship. So to look at this in the Trailblazer-ALZ 2, the donanemab study, individuals were split into deciles by how low the lowest they got in their amyloid post baseline. So if and that sort of set out in the graph on the right here. So there were some individuals who got really low, so they got down to 0. That's deciles 1 or 2, and then there were people in decile 10 who really their amyloid is at a very high level, probably unchanged from baseline. And so looking then at how the how low people got on their amyloid at some point with by decile with each of these various cognitive outcomes and biomarkers was looked at. I'm just picked out just really a couple. So if you see here, this is the IADRS again, and the CDR sum of boxes. in the fully red circles of those which are just have only really got donanemab participants in. And then, have you noticed they're all scattered up to the left? That's because it was people treated with donanemab who got lower, as would be expected, amyloid uh, values in terms of centiloids. And the people on the right of each of these graphs are more likely to have been on placebo because they didn't achieve um, a low centiloid level. But there's a spread because, of course, the placebo and the treatment group had a spread of amyloid levels. But what you might want just to focus on, if you just focus on the red dots and almost exclude those with gray, because in some ways that's probably statistically a more robust question. Within the treated individuals, was there a relationship between how much lowering there was of amyloid, or how low people got, not how much lowering, but how low they got with the cognitive outcome? And I think there is a suggestion here, support for those people who got lower amyloid reduction, how they got as low as down to really low post baseline levels, did better, and that seemed to go decile by decile across the cognitive and amyloid level outcomes. So, in summary, while we know what the average centiloid reduction was, lower baseline, post baseline amyloid values correlated with slower decline, and also with positive, as we would expect, plasma biomarker changes. So again, this suggests that the changes on the amyloid PET uh, are how low you get does indicate how well you might do. What about real world implementation then? This is a report or a presentation that was a very nice presentation at ADPD by Dr. Rosenblum, looking at a huge data set from the Purple Lab Clear Claims database. There's a few things I'd like to pull out. They looked at people who'd had lecanemab between January 2023 and December 2024. So things have been building up in this time, but this is in the early initiation and the early phase of our experience of real world evidence, and this will grow. But in this period, at least, you can see on the right that nearly all of the patients who were given lecanemab were being treated by neurologists when lecanemab was initiated. If we now look at the demographics of who received therapy, it is predominantly people who are white and who are in an urban residence. So perhaps that's not that surprising, but it does suggest that we need to think about how we will reach the wider population. And these are probably um, perhaps unexpected, not unexpected, but we do need to make sure that we have a more equitable and wider distribution. If you look at the age distribution at the top there, as expected, we might have we are probably having a slight preponderance of people who are younger. But if you look at the diagnoses, that's the bar graph on the top right, dark blue. Most people have got Alzheimer's disease rather than mild cognitive impairment. And those of you who are being particularly astute may notice that the two percentages don't add up to 100, and that's because some people had both diagnoses. Um, there's a widespread of comorbidities. So these were people, these are patients with a fair spread of comorbidities such as raised lipids or high blood pressure, as one might imagine. So the key finding from this is that comorbid conditions were common. The finding was that people did adhere to their number of and the frequency of lecanemab administrations as had been proposed and as in the trial. So pretty much about two administrations a month, and the guidance is it should be every 2 weeks. So that's very similar. And we while access is increasing over time, there are real disparities between rural marginalized populations and urban white populations, which we do need to address, and hopefully will change it in time. So now I'm going to talk a little bit about something that I personally have been involved in, rapid MRI in this new era. So a real problem that we've got is that there's pressures for diagnosis, rightly so, and hopefully that we will improve this. We need diagnosis to get eligibility for disease-modifying therapies, and and for eligibility, we absolutely need MRI. So a CT scan is not acceptable to initiate disease-modifying therapies. And yet, in many parts of the world, getting access to MRI is difficult. It's more costly, and patient cooperation is important. You've got to lie still for a number of times. So the possible solution that we were thinking of is, could we abbreviate the MRI protocol, only the essential sequences, accelerate those sequences that would improve patient comfort and compliance, throughput, and increase access to treatments. So we decide what would be the minimum essential protocol that we could get away with. So they're listed there: a T1 weighted for volume, a flare for hyperintensities, for vascular load, an SWI or T2 star, so that we can that key eligibility criteria of not having more than 4 microbleeds, and a T2 weighted sequence. So the question we set ourselves is, could we take the standard time for those sequences would be about 20 or so minutes. Could we reduce that significantly? Let's down to 6 minutes. So here's the sort of interactive bit. If you can have a look at these two scans on the left and the right, you'll notice that that one on the left is only 90 seconds, the one on the right is 5 minutes, and I would argue that you really would be hard pushed to say one or the other was better at assessing hippocampal atrophy, or in fact atrophy overall. So we've got no loss of quality. If we do the same here, this is for with the flare, with the acceleration down to under 100 to about 100 seconds, we can see the white matter hyperintensities just as well. We can do the same for microbleeds with similar acceleration factors. And so overall, we would be able to image atrophy for trial inclusion with the same sort of speed. So what did we see when we gave these scans on a blinded basis? A panel of radiologists, neuroradiologists, experts did not know whether they were seeing the fast or the standard scan. And what we saw was inter-rater agreement between different radiologists was similar, in red if it was the clinical scan, or blue if it was a rapid scan, for all of these measures. But what we also saw, the inter-rater uh, uh, agreement between radiologists was lower than the between scans types, which were closer on all these markers, closer to one, suggesting that we are having the scan type, accelerating scan, has no loss of quality, and the variance is much less than the difference between radiologists, or even between day of the week that it's read on. And if we have 3D acquisitions, we can match scans and subtract them. What we see here, if you see on the left of your screen, we can see the rapid scans that are done, and now that allows us to match them and subtract. So what we can see, if you look at there is somebody with ARIA-E, and you can see that on the flare. If you look very carefully, if you know where to look, on the second of those two scans in your top left panel, now when we do the on the top right panel, where we've subtracted the scans one from another and given a false color red yellow overlay, you will see that the small ARIA-E focus jumps out at you. It's bright yellow. And the same happens if we even on the volume scans, MP-RAGE, where it's really, really hard to see any difference between those two scans and the bottom left of your image. But now if we false color, subtract them with a fluid registration, as we call, you can see that red dot, which is where the ARIA-E is. So what's next for MRI? I think focus protocols with accelerated sequences, we can do at least 3 times the speed. So that will massively reduce burden on patients, but also increase the throughput. I think we need to sort out the eligibility um, being dependent upon what sequence is used for microhemorrhages, and I think we can pick up change. In the long term, we'd like to see if there's disease-modifying therapies slow atrophy. And for all of this, I think AI is going to be altering our clinical practice, giving decision support tools, whether it's atrophy or microhemorrhage count or staging. So a quick update on the plasma p-tau217, which I feel this is really is a game changer in terms of clinical practice and really will open wider access to people. So again, I'll just walk you through this slide. This was Sebastian Palmquist presented this at ADPD 2025, and what they took is a whole load of different cohorts. If you just look at the graph on your top left, there's a cohort from Gothenburg, a cohort from Barcelona, a cohort from Brescia, and a primary care cohort. And having set the cutoffs with one cutoff, which is the top set of the top row there of little graphs, you can see on the 90% accuracy and positive predictive value and negative predictive value and area under the curve as we move across there, we can see that was the Malmo cohort. That was the Swedish cohort that was used to set the cutoff. And what we can see is really remarkable. Gothenburg, Barcelona, Brescia, they're very similar. Those dots, the orange, blue, red, and green, they're very similar to the Malmo. So this really very consistent performance as we go across with a single cutoff. And there's interest in using two cutoffs. So the single cutoff says, are you likely to be amyloid positive or amyloid negative, or is it likely that you've got amyloid pathology in your brain or not? With two cutoffs, that says, well, actually, we want really to make sure that we make can get a very high level of specificity that you have got or have not got amyloid in your brain. So you can set two cutoffs, one above which you're very likely to have amyloid pathology, and then a lower cutoff below which you're very likely to be normal, and then a gray zone which may need um, uh, intermediate values, if you like, where might need a bit more judgment or maybe a CSF after all. And that in the graph on the bottom right, you can see that the very similar levels of the people in the intermediate level when you've got the two cutoffs across these cohorts. So around 15% or about 1 in 7 people fall into that intermediate. So we're actually classifying as positive or negative the vast majority of people, irrespective of these different cohorts, and you're still left with the two cutoffs with a small, reasonable level in the gray intermediate zone. So in conclusion, there's high accuracy. We've known that already, and the two cutoff approach is helpful if it's a standalone test, maybe particularly in primary care. And this will have a great impact on the need for lumbar punctures and amyloid PET scans. And this is increasingly important, particularly in countries where there's reduced access to amyloid PET or to CSF testing. So the take-home message was that if we embrace these advances and incorporate them into our workflows, we can improve care for patients. We can reduce, and I hope there'll be similar reports like this of the modified titration schedule for donanemab, which does reduce the risk of APOE, of ARIA-E in people irrespective of APOE for carriage, which is really great because it didn't alter the rate of amyloid clearance. It does seem like with the subgroup analysis of those people with early disease and those people who had cleared the most amyloid, saw greater slowing and greater benefit. So diagnosing and treating early. This is a recurring message that you'll be hearing. If we can get people in early enough, they may get the greatest benefit. Our real world studies suggest high adherence rates, but they also suggested that people are not getting in at the very earliest stage. Now, hopefully, as time moves on and systems gear up, we'll be picking up people earlier. And there are real barriers in that, both in terms of healthcare system readiness, the ability to deliver MRI, and there are some ways we can get over that, but also we can see that people who are um, uh, urban, wide, or high socioeconomic status have a greater utilization and greater access to these therapies. Plasma p-tau 217 and really, I think offers. It's just so obvious that we should be using it, and it's much less burdensome, much less costly, and it has really high performance against CSF or amyloid PET. So I'm just going to end with thank you for your attention, and a look to the future, because I think there are great challenges and opportunities. So molecular biomarkers does make possible a more precise pathology-based diagnosis in dementia, diagnosis of Alzheimer's disease, in a way that we've seen transformational in diseases such as cancer. Plasma biomarkers offer the potential to expand use, but we need to be careful about how we interpret not new biomarkers. I think similarly, MRI could be increased to increase access. And these new therapies are a long-awaited advance, and they are appearing to be most effective in very early disease. Many patients with later stage or non-Alzheimer's disease or have contraindications will not be eligible, however. And there will be disappointments for many, but our hope for the future is that we can produce improvements in care for the many, not just those eligible for the anti-amyloid therapies that really are a major advance that has been long awaited. I hope that this will actually lead us to more of an end to the nihilism that we've seen all too often. Thank you very much for your attention.
Thank you for listening. Remember to download the slides and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/BRK860.